Welcome to the Heart of It, where we take you to the heart of healthcare. This season, we're exploring what happens behind the scenes at Fraser Health to ensure patients receive the best care possible. Fraser Health provides care on the traditional, ancestral, and unceded lands of the Coast Salish and Inklakatma nations and is home to 32 First Nations within the Fraser Salish region. Fraser Health is dedicated to serving all Indigenous people and honors the unique cultures of the First Nations, Métis, and Inuit living within the Fraser Salish region.
Welcome to the Heart of It. I'm Dr. Victoria Lee, your host. I'm privileged to be joined by Tammy Dyson, who's our lead for medical assistance in dying, as well as Dr. Collins, who is our palliative lead physician for Fraser Health. Welcome. Thank you.
Thank you very much for asking us to join you today.
Well, let's start with some of the basics. And I'll start with you, Dr. Collins. How would you define palliative care?
Yeah, no, it's a great question. We're a relatively new profession, to be honest with you. It only originated in the 1980s. Palliative care is really about focusing on what's important for the patient and their identified caregivers, their family. So that could be symptom management like pain or nausea control. It could be helping out with their mood, with their anxiety, their depression, or even existential distress. So that fear of end of life.
Yes. And end of life is not usually a comfortable topic for most people. And I think, Tammy, you've spent quite a bit of time in this field. Can you tell us a little bit about your background and what led you to working in end of life?
Yeah, no, absolutely. And you're right. There is a lot of discomfort in talking about end of life. I don't know why, but I do have comfort talking about it. And that may come from my over 20 years of working within palliative care and in the last 7 years with medical assistance in dying. I certainly acknowledge that end of life and talking about one's death is very much driven and impacted by someone's culture, their faith, and just their own personal preferences. So being able to engage in those conversations and being mindful of every aspect of that person, it can be delicate, but it can also be incredibly rewarding to be able to have those kinds of conversations.
Yeah, and I think there's that dignity of human life, even towards that end of life, where can be very sensitive and delicate, as you mentioned. So given that it's such a culturally diverse setting in Fraser Health with 90% of refugees and 40% of newcomers that settle in our region, and different cultural practices from our Indigenous communities and Métis communities as well. How do you navigate those conversations in a culturally safe way? Maybe I'll start with you, Andrew.
Yeah, honestly, some of it may be just asking the patient. So they may come from a particular cultural background, but asking them what's important to you, what matters most to you, and using that as an open-ended question to really explore their own personal beliefs and values. In Fraser, we have all of our documents actually translated into every single language that we are fortunate enough to have within the health authority. But having that open-ended conversation can really just guide and allow us to understand what's important to that patient, what cultural beliefs they share, what end-of-life practices they may want to receive.
Yeah. It's all about, as Tammy mentioned earlier, about personal beliefs as well. And I don't know, Tammy, if you have any personal stories or patient or family interactions that kind of stick out to your mind in the past, I don't know, decade or so, that might be worth sharing with our audience.
Yeah, well, certainly medical assistance in dying is it is so specific and it's relatively new here in Canada just in the last 8 years. So because MAID in and of itself is completely driven by the person who's requesting MAID, they're the one who's reaching out to us. So we really are able to engage in a very concrete discussion around their death. And often people will feel relieved that they have an environment, they have someone that they can talk to around a readiness to die. And for some people, that readiness to die might be a year from out, and for others it's, wanting it as soon as possible. So it really is around navigating that. And it's interesting how Andrew says, we ask what's important to that person, and with MAID it's actually the same question, which is, as we approach the day of your death, because of MAID, you identify a date and a time. Is there anything that's important to you? Is there anything culturally? Is there anything that you would want us to be able to support you with, or that we want to make space for?
Yeah. And I guess whether it's end of life or other healthcare interactions, it always goes back to individual belief and preference as well in terms of the treatment options that might be preventive or management or rehabilitation or even in palliative care. So going back to you, and I'll come back more to May because I think there's lots of information that people would love to hear more about. But what is the physician's specific role in palliative care or end of life?
So I actually work with a group of team members. So I'm a physician on the palliative care team, but I work with social workers, with nursing, with pharmacists, with spiritual health practitioners. My role is really to help with the medical aspects. So it could be prescribing medications, for example, to make sure that they're comfortable. It could be helping out with care planning to make sure they're receiving the appropriate equipment or resources in the community, to help with that transition, and sometimes to help with end-of-life or advanced care planning conversations to make sure that they're set up with the information to make the best choices for them for their future healthcare needs.
And going into that area of like the team-based care, I think sometimes people are not aware that everybody's working together. And like if we're looking at it from patient's journey, before you get to that end-of-life kind of perspective, what are the kind of the trajectories that you see patients coming into your care?
Yeah, we have an integrated palliative care network here in Fraser Health. So we support patients in all areas of healthcare. So if you're at home and you're being supported by your most responsible practitioner, whether that's your family doctor or your nurse practitioner, you may be receiving palliative care through the home health team. So dedicated community nurses that are going out to support you, who are acting sort of as air traffic control, connecting with your doctor and the palliative care team to make sure that you're okay. If you transition over to hospital, it may be the acute care team that are looking after you. And that could be sometimes the dedicated palliative care team coming to see you in the facility. So regardless of where you are, we're always available and ready and able to support you. That's from Burnaby to Boston Bar and in every acute care facility that we have here in Fraser.
And that's an important point, isn't it? Because sometimes people see palliative care as like a discrete service, or you're receiving palliative care, end-of-life care, if you're in this ward or service department. And what you're describing is really there's different ways that palliative care services are now delivered.
Definitely. So someone can be receiving palliative services and still getting active chemotherapy with the intention of curing a condition, or getting active treatment for their congestive heart failure or their lung condition. Palliative care is about symptom management, making sure that we're having good quality of life in the face of a life-limiting illness. That doesn't necessarily mean the last hours or short days of life. It could be the last years of life.
How do you define when you're actually eligible or when you should be thinking about end of life or palliative care?
Yeah, so I kind of think of it as the time of diagnosis. So at the time of diagnosis of a life-limiting illness, you may be having conversations with your specialist or with your family physician or nurse practitioner in the community. They may be providing palliative care, and that might be adequate to control your symptoms, to make sure that you're having informed conversations about treatment options and holding advanced care planning conversations, for example. But as things change, as your condition changes, that may activate services for more specialized palliative care team members. Generally, we support people in the last year of life, and that could be shorter for some people because they've been expertly managed in the community by their team, or it could be longer if you don't have a family physician or a nurse practitioner, for example.
Just to build upon a little bit of what Andrew said, I often think of palliative care as more of an approach to care. Yeah. So that someone can be pretty far out, like if they've just been diagnosed and perhaps their prognosis is many years, one can still adopt that palliative approach. It may not mean that you're going to have a specialized palliative consult team come and see you at home, but it's around having those really robust goals of care conversations that as things change, what is important to that person, what kind of medical intervention do they want to have. And it's often good to include the families in that conversation as well, so there's more transparency ultimately it does come down to the patient for sure, but if at some point they lose the ability to communicate, that the family or also the loved ones are also aware of what that person's wishes are.
And Andrew, you touched on advanced care, and advanced care planning is very important. Can you describe what that is?
Sure. Advanced care planning is letting your future care team or even your family know what your wishes, values, and beliefs for treatments may be in the future. It's a big umbrella term. People are very familiar with doing a will and funeral arrangements, for example. That's advanced care planning. But taking things a little bit upstream, it may be letting them know what treatments you may want in the future or what interventions you may agree or disagree to have should things change and you're unable to speak for yourself.
And I think that's an area, again, there's a lot of discomfort around. And I think we know from being on the provider side of things that when an individual, as you talked about, when a patient makes their decision based on their values and beliefs, it might be different than when loved one is in a position that they're in a way forced to make those decisions on somebody else's behalf. The comfort level is not necessarily there. And there might be other things that go into consideration in care decision making. So how do you make that conversation or advanced care planning as part of everyday life as possible? Is that something that we should be striving for in our society?
I think so. Honestly, if you just go to Fraser Health's website and type in advanced care planning, you're going to get a lot of resources that are very helpful to hold those conversations with your loved ones. There are video clips telling you how to bring up that conversation when it feels uncomfortable. There's also even games from the BC Centre for Palliative Care, where it's like a playing card deck, where you turn over the card, read out the question, and provide your response. So there's so many innovative ways of actually starting that conversation and having deep, meaningful interactions with your loved ones about future plans.
Yeah, I think it's one of those things sometimes people just avoid, but it makes such a big difference for, I think, one's dignity, going back to one's dignity and how do we actually ensure that we are and we are providing care to that one's wishes and values. And would you say, Tammy, like from the patient population that you see, what would be proportion of people that actually have that advanced care planning done or not?
Well, it's hard. It's hard to say because often people will get a lot of calls at the MAID Care Coordination Center that someone is wanting to put MAID in their advanced care plan. So I'm always heartened to know that those conversations are being had. That isn't currently legal here in Canada, but there is an appetite to be able to have that be available specific to MAID, but I am grateful to know that those conversations are continuing to happen.
Any sense from your perspective, Andrew?
Every single person should be having those conversations and completing documents right now, today, regardless of your health. It doesn't have to happen at the time of a diagnosis or even the final days to weeks of life. People should be having those conversations while you're healthy, things are good, and you're just making plans for the future.
Yeah. I presume you have one.
I do, yes.
Yeah, and I'm just feeling guilty because I don't have one, and I'm going to get on it because, I do think it's one of the very critical and personal decision kind of thing that actually makes a huge impact for your family, your loved ones, as well as your care teams that give everybody much clear direction, right? So I'm going to put it on my list to do for sure, advanced care planning.
And since you're talking about that, there's a tremendous resource called My Voice. Okay. So if you go on the Fraser Health website, you'll be directed to it. It's a provincial document, and it takes you through all of the steps for everything that you can possibly imagine for advanced care planning. Identifying a temporary substitute decision maker if you were unable to speak for yourself, who would be appointed as a representative if you don't like your temporary substitute decision maker, and it takes you through everything, start to finish.
Let's talk a little bit more about end of life, and we talked about kind of decisions and discomfort in our society and some of the cultural factors that sometimes get into that conversation as well. In our kind of healthcare, there's also been kind of a long kind of view, or maybe it's more of like the way we're trained to think of avoiding death and dying is what we do on a day-to-day basis at a system level and at a clinical and team level. So it's very difficult even, we're talking about the patients and families and having these conversations, but it's not easy for healthcare teams either. So what do you see as some of the progress that we've made in this area, and what are some of the challenges that we see? And I'll start with Tammy.
Yeah, well, I think even having a series such as this talking about death, I think is part of that progress for sure. Being more open and talking about it, and I mean, with that comfort level does come being more knowledgeable about the resources that are available. I feel that Fraser Health has done a fantastic job with advanced care planning going back decades. And so that there really has been that integration to have these conversations for the nurse at the bedside to ask around, in terms of, this is what I'm observing. What is something these are your options. What feels right? What resonates with you? And also being able to address the loved ones that might be involved as well. So someone might be making a decision that the family does not agree with or would find that very difficult. So certainly also why within palliative care it's so great to have that interdisciplinary team to be able to address all aspects of that person's movement and journey towards the end of their life.
I sometimes struggle through some of this because on one hand, death and dying is a normal part of our life, and at some point, it's going to happen. And sometimes it's sudden, sometimes it's long, and sometimes it's, after a very fulfilled life, and there's many different journeys. But there's also now longevity medicine and longevity research that see kind of overall aging as an illness and treating that as one of the interventions. And there's lots of research that's happening in that area. And I find it kind of interesting to hold both at the same time as what's happening in our current realm of evidence. I don't know if you have any thoughts on that.
It's tough, right? It's that tension. We spend so much healthcare dollars even just on what could be the last 30 days of life with ICU admissions and repeat visitations to the emergency room. We're struggling with end of life, but it's a natural progression. It's something that happens to everyone, fortunately or unfortunately. Our goal is to make that peaceful, but I can certainly appreciate that dichotomy and that tension between everything that's happening now with longevity and sort of palliative care.
Yeah. Well, and as you mentioned, vast majority, I think it's around 80% of healthcare dollars actually go into the last 18 months of people's lives, right? And I think that's where, again, advanced planning is quite helpful, because sometimes decisions are made on one's loved one's behalf that might not be the right decision for that person. I don't know if you've ever seen that occur in a real life setting in the experiences that you've had.
Definitely. I've seen people who weeks down the road, their loved ones would say post-stroke, for example, when they're unable to speak or feed themselves, they never wanted to be like this. Mm-hmm. But because they didn't have an advanced care directive or clear wishes expressed, decisions were made that perhaps were not ones the patients themselves would have made. Mm-hmm. And so we land in a place where they're receiving aggressive care. Maybe they're receiving interventions and procedures and tests, but they never would have wanted that. Yeah. And I see that on a day-to-day basis, unfortunately. Mm-hmm. It speaks to the value of advanced care planning and letting everyone know while you're healthy today what your wishes might be for the future.
Yeah, and it's not one and done. You can dynamically change as your perspective and wishes change as well. And speaking of one's wishes, sometimes people do have preference and choice that they make in medically assisted dying. And can you speak about what it really is in terms of medical assistance in dying, and what does it involve? Because I think it's kind of an unknown realm for most people still.
Yeah, it certainly can be. And I quite like the dovetail from this conversation, because as we're talking about advanced care planning, it's going back, we'll talk to family members and they'll say, oh my goodness, I know that my mom would have wanted MAID even before it was legal in Canada. This is something that she's been talking about. If she couldn't do this, she would want to have an assisted death. So it's all part of it, that those conversations can be formal, but they can also be quite formal. And working in palliative care for as long as I did prior to MAID, it wasn't uncommon for people to say, I'm just done if there's just a pill. So in 2016, in June of 2016, the federal government did set the eligibility criteria for MAID here in Canada. And so what MAID actually is where a capable adult can go through two different assessments to be connected with a physician or nurse practitioner that will administer medication that will end their life, and that is at their request.
Is there specific eligibility criteria that's for overall and patient population? And then there's been a lot of conversation about mental health patients as well. So maybe you can speak a little bit about that.
Yeah, so the current eligibility criteria for MAID is that they must be 18, they must be eligible for publicly funded healthcare, so that often means MSP. And most significantly, that request must be coming from the person themselves. So no one else can make that decision for them. And someone must be living with an illness that is advanced and irreversible, and that they are experiencing suffering that is intolerable to them because of that illness, because of their medical condition.
And did you want to speak about what's going on with mental health?
There were changes to the legislation in 2021, and part of that was that someone who their only diagnosis, their sole diagnosis, was that of a mental health condition, defined as a mental disorder in the legislation. So in 2021, the federal government said in 2 years, someone can make that request and could be considered eligible for MAID if their sole reason for requesting MAID is because of a mental disorder. So that's been pushed back a few different times, and so that now brings us to June of 2027, when that is to be discussed again. So until that time, it's the eligibility criteria that doesn't involve someone with their only reason being that of a mental disorder.
Say, Tammy, that I'm somebody that is considering MAID. What would be the kind of the patient journey from that patient's perspective?
Mm-hmm. Well, I think that first you would probably be talking perhaps to a palliative care clinician who would want to make sure that what it is that you're asking for is medical assistance in dying.
And would you do that through your primary care doctor, or through, is there a number or like an application form on the health authority website? How does it work for those that have connection to primary care versus not?
Mm-hmm. Almost all of the above. If there's anyone out there who's wanting more information about MAID, they can certainly call the MAID Care Coordination Center in Fraser Health, or actually any other health authority in BC. So there's one phone number and one email for people to contact us. And it's also great if primary care providers can also engage in that conversation as well. And if that person does want to make that request for MAID, they would be filling out a form that they would access from the Ministry of Health website.
So you fill out a form and you're either directed through central kind of coordination or through your primary care provider to speak with somebody like Andrew, Dr. Collins, and then you have an assessment by a palliative care physician. Is that the next step thereafter?
No, not necessarily. There's times that someone like Andrew or a member of the palliative team will reach out to our team and say, we have someone who's requested MAID and we're sending in that person's request form. And so that is great, knowing that person is well supported. But when someone sends in a request form to our program, one of our coordinators will reach out to that person and check in with them and see how they're doing, if they need any additional supports, and check in to see if they want to start the formal assessment process. Because sometimes people just want to put their request in for MAID, and that's enough for them. And then there's other people that will contact us and they want to proceed with MAID as soon as possible. So if someone did want to proceed more swiftly, or if they just wanted to have everything in place, then the process would be that there's 2 medical assessments that must be completed by either a physician or a nurse practitioner. And the first assessment, we do tend to reach out to a primary care provider, which can include Andrew, and other people that are involved in their care. So most often we'll turn to a family doctor or another specialist. And then after that assessment, that second assessment is someone who has been authorized and had additional education to actually be the one to administer the medication. So most often that person wouldn't know that person that would be coming out. So again, either a physician or nurse practitioner, and would be coming to wherever that person is, whether they're at home or in hospice or in acute care. The team at MAID Care Coordination Center does the matching.
Okay. So it seems like in terms of patient journey, it starts with, again, the patient identifying MAID as a service that they want to learn more about, explore, or want to proceed with. And then you're directed to the Central Coordination Center. You get a check-in. And then if you want to proceed, then there's two-step kind of first physician, second physician validation, and then the MAID service may be administered at that point at the end of all of that assessment. Is that accurate in terms of the overall?
Nurse, or a nurse practitioner. But it's the person who's requested MAID drives the entire process. Okay. So if at any point someone is not wanting to proceed with an assessment, or perhaps they've taken a trip and they are just, they have other priorities, we back off. Yeah. So we follow the lead of the person who's requesting MAID.
So it's very much patient preference, timelines, and in each step of the way, you can say, okay, I've had a different thought and I'm going to change my mind or just put this on pause.
Absolutely. And if we did otherwise, that actually wouldn't be legal, because it is completely driven by the person, by the patient.
And you mentioned hospices where it can take place, home, long-term care, so it's quite open to any kind of a location.
It is, yeah. So MAID in Fraser, we're a regional program, so we do support people in whatever setting that they are in. There are some exceptions if someone is in a faith-based setting of care. That facility has the choice of whether or not to transfer them to a different setting of care for the provision of MAID.
Sometimes people are comparing MAID versus palliative care, whereas I think all of the conversation that I've had with palliative care teams or physicians, it's an umbrella of overall we have end-of-life care, and then MAID is one of the components, but it's not the component, and similarly it's a wide kind of and expensive and diverse service options that are available for end of life. And I don't know if, Andrew, you encountered those kind of conversations and how you respond to that.
Yeah, I would agree with you. To be honest with you, it's the umbrella term again of end-of-life services, with MAID being one option. In Fraser Health, we have separate care teams that provide palliative care and a separate care team that provides MAID. I would say my experience has been about 80% of the patients who have MAID, and I'm looking to Tam to confirm this, but they're connected with palliative services in one way or another. But there is 20% that are not receiving palliative care and maybe outside of our service criteria because they have many potentially years of life sort of ahead of them. So it is an option, but they're not the same.
And is there that touch base when MAID conversations occurred to see if there's interest in palliative care or other options, Tammy?
Yeah, there's people that will phone us and they'll say, I want MAID. And the team will explore that a little bit more, and it's, I'm in terrible pain. And we know that they're living with a life-limiting illness. And so with the patient's consent, we will then reach out to teams to get the right referrals in for that person to address that person's suffering. And that is the shared cornerstone for both palliative care and MAID, is that we are here to address suffering. We just go about it in a different way, but we are here to support someone to be able to live the life that they want.
And what do some of those conversations look like, Andrew, from let's look at it from that broader umbrella of end of life, and how do you, what advice do you give families in supporting their loved ones as they go through end of life overall?
Each journey is really unique. So it's hard to give the pattern for every experience, but certainly making sure they have medical information, that they're completely up to date with where things are, and potentially the time that we have ahead. It could be exploring where end of life may happen. Some patients and families choose to remain at home and have a home death. So we're going to be putting in medications that would support that, putting in documents to make sure that everyone is aware that's the plan and the intention, so there's no urgent 911 calls, for example. It could be having conversations about how we, as a palliative care team, can handle the medical piece, but they can be family in a care setting like hospice. Or if patients want to know all of their end-of-life options, even discussing MAID or medical assistance in dying with them, because that may be the care choice that they wish for their end.
And oftentimes I hear about how most want to actually have their last days at home. What are we doing to support that from Fraser Health?
Yeah, so we have tremendous care aides. So I'm going to start with that first. They're able to come in and help out with personal care. So that could be helping you get into the shower or a sponge bath if you're unable to get out of bed. It could be changing the linens of your sheets, for example, or even doing respite care so your loved one can step out and do some of their activities like grocery shopping or getting a Starbucks coffee for 5 minutes. But we also have home health nurses. So they're the team that are going to go in and help make sure your symptoms are being controlled. They're going to connect with your family provider or your nurse practitioner or the palliative care team if we're involved in your care. And we're going to help with medications, either by mouth or under the skin as a little injectable port. And we're going to also provide potentially private pay nursing. So some families opt to have 24/7 care in the home so they can receive end of life at home. And we also have occupational therapists and physical therapists who go in and do assessments and provide equipment to make sure that everyone is safe, even up until the end.
We talked about various places where you can get end-of-life care, whether you're at home, whether you're in acute. There's also specific care where we can also deliver end-of-life care. Can you talk a little bit about hospice care and what that means and what that looks like?
Yeah, sometimes people get hospice and palliative care kind of mixed up because there's a perception that they mean the same thing. The truth is you can receive palliative care anywhere. You can receive it in your home, you can receive it in acute care, or you can receive it in a physical building that's designed for end-of-life services. So that's what we call hospice care. It's an environment where there are nurses and doctors and other team members who are going to look after your medical piece and allow your loved ones to become family again. So you can bring in your dog, your cat. We've even had a horse come into hospice because that was an important family member. And you can receive that end-of-life care there. If you're feeling well, you can go out for the day. Feeling really well, go out for a weekend. But you have a safe place to come back to, so you don't have to access the emergency room or other environments. People generally come in when it's getting a little bit hard to be at home, and they typically stay for weeks to short months, but we've had patients that have come in for longer than that as well. It's just a secure place for end of life.
And hospice care is available for all ages, right? And it's not just for certain type of a patient population.
It is. Generally, the people who are less than 18 use Canuck Place in Vancouver, but here in Fraser Health, I think we have a satellite Canuck Place site as well that they can receive care. Yeah, it's a beautiful building with a beautiful garden as well. Our hospices that I'm thinking about in particular, we have 10 facilities throughout the health authority. They're generally for people who are 18 and older. And the dedicated team at Canuck Place in Abbotsford would look after our younger population.
And I believe there's also some sort of services available for people that are not based out of the hospice facility per se, but more of an outreach as well.
Yeah, most of our physical hospices also have what we call hospice societies connected with them. So those are the team members that are providing counseling services. They may have day programs, for example. They may have outreach counselors who are able to help out with grief and bereavement pre or post loss of a loved one. Some conversations can be really difficult for our younger family members, for example. So having someone with counseling skills who's able to sit down with an Xbox and have that hard conversation can be really helpful for families. And all of those services are provided by our hospice societies. Generally, we have one in every community attached to our physical hospices.
That's really wonderful because I think it's the person that's going through it, but the loved ones also have their own journey and pain and sometimes loss and also a acceptance of that end of life. And I think we need resources to support families and loved ones.
Definitely.
And that is one of the principles of palliative care, which is that the patient is not just the patient. It is actually their circle of care as well.
And I just remembered one of the conversations that I recall having a researcher on death and dying was about how one of the cultures, if you spoke about it, death and dying, then it'd be 4 generations of bad omen, that type of belief, more of the cultural belief, which is also legitimate in terms of cultural beliefs. And how do we actually talk about it if it's going to bring bad fortune or omen to family for generations thereafter? So how do we navigate some of this, and what's a culturally safe way for us to do this in such a diverse setting that we live in? Because it's much more than translation in terms of how do we it's beyond language. How do we culturally translate care, like advanced care planning and death and dying conversations?
Some of it is just asking the patients and the families. So asking what's important to you, what beliefs do you share, what would you like to share with me about what's important to you. Even as simple as, can you tell me what you understand about your condition? That can be eye-opening for a healthcare provider to hear the word cancer not used, for example, because it's taboo, or to hear the oncologist has said end of life, prognosis of 2 months. It's eye-opening when you just ask that open the door question. Tell me what you understand about your condition. And for some patients, for example, they don't even want to participate in the conversation, and they'll say, speak with my son or my daughter or my husband or my spouse. And that's okay. As long as they're directing that care, it's okay to speak to someone separately, to have that conversation even outside of the room, because we don't want to cause trauma by having conversations about something that they don't want to participate in.
Yeah, and especially when it's so sensitive. Yeah.
And on the other side of that too, there's people where culturally they would not be in a position where they would be want information, but they're wanting it, and it's the family where it's coming from a good place that they are protecting their loved one. Yes. And so then it's asking the patient, again, completely directing those conversations around, if there was information about your medical condition, would you want it? Mm-hmm. And so to give that person that opportunity to learn more should they want to. And I mean, here in North America, we do value autonomy, and we certainly acknowledge that is not the same around the rest of the world. So to be able to delicately go around that, but still making sure that we come back to the patient, that we are addressing what it is that they want to know. And it is, it's certainly when we have that clarity, talk to my family, that's great, and that's very clear. But sometimes from a very good intention, people can start to just talk to the family and not go back to the patient.
So if you were to recall a story, whether it touched your heart or reflects some of the experiences that you shared today, what would it be?
One of the very first patients that I had here in Fraser Health was a very young gentleman who was in my hospice for end-of-life care. He was in his early 20s. His favorite thing to do was to have wings and a beer on Friday with his friends in university. But unfortunately, he was diagnosed with a brain tumor. And he very quickly lost the ability to walk, the ability to see, and from day to day, sometimes the ability to talk. And there's never a good time for a family to be going through this, but it happened.
Very rapid too.
Definitely. And it happened to be during Christmas. And they had another sibling as well. The patient had another sibling. And the family were really struggling with, do we celebrate Christmas this year? Right? Yeah. You have a loved one in hospice. Yeah. He has short weeks of life at best. Do we really celebrate the holiday? But we could see that tension that was happening in the family, and it was spilling over to the care team because we were struggling with how they were feeling, because we wanted to be able to address it. So the nurse that I work with and myself actually got consent from the patient to do a thumbprint in a piece of clay, and we made it into a necklace for his mom and a keychain for his dad. And the nurses actually wrapped it up for Christmas, kept it in the same drawer as his pain medicines and his nausea medicines so that no one would see it. And then on Christmas Day, played the Santa Claus and actually handed it out to his family.
Oh my gosh, what
So
a
while
beautiful story.
while they didn't celebrate, it was
Yeah.
still such a moving experience.
Yeah, what amazing and very memorable.
Yeah, I bet
Very
there wasn't
touching.
a dry eye in the house when that happened, I bet.
Oh my gosh, I can only imagine.
Yeah.
Tammy?
Yeah, it's when I worked in end of life care, I always said that people die the way they've lived, and I wasn't quite sure with MAID if that was going to be the same, and it absolutely is. And one woman absolutely stands out to me, which was a woman who was at home, and she was living with advanced cancer, and she made a date that she wanted to proceed with MAID. And before her death, she made a bunch of meals, about 5 days worth of meals, and put them in the freezer. She said, because I know that my family are really going to be struggling, and I want to make sure that they have nourishment. I want to make sure that they have good meals, because it's going to be hard for them.
Oh my gosh.
And so she died as she is still taking care of her family even after her death. So it's very much, I believe strongly that people can die the way they've lived.
Oh my gosh, almost brought tears to my eyes. That's, and you can think of a lot of people that are like that in life that would do exactly what you're talking about, right? So, wow, that's a powerful story as well. Thank you so much for sharing your insights and expertise and experiences. I'm curious about, if you look at future of healthcare, how would you describe it in one word? And maybe I'll start with Tammy.
Yeah, it's a good question. One just reflecting on, I actually feel I'm reassured. I know that there's a lot of people that certainly recognize that healthcare is a difficult place at times, and that just listening to people and the leaders that are coming forward to make changes, to adapt to the changes that we've seen in our healthcare and the delivery of it, I feel reassured about the people that will start to make the shifts that maybe should have been, made decades and decades ago, that were just couldn't be predicted.
Thank you. Andrew?
For me, it's a similar thought to Tammy, to be honest with you. I think the word would be transformational. We've gone through such a flux in the Canadian healthcare system over the last number of years, and we've been able to see how people can, and the system can, pivot in a remarkable way so quickly when we need to. And I think that transformation is sort of what we need over the next 5 to 10 years as well. Not to lose those quick wins, those agile maneuvers to actually improve patient care. So that would kind of be my word.
Absolutely. So both very, very, I think, touching words for a future of health system as well. So thank you again for joining me today.
Thank you for
so
the
much.
opportunity.
Join us next time as we continue to get to the heart of healthcare. Don't forget to rate and subscribe to this podcast. The Heart of It is produced by Fraser Health Communications and Public Affairs.